Hello everyone, and welcome to the CoROM Podcast. This is where academic medicine meets remote, austere, and resource-limited areas.
So, welcome everyone for today's CoROMcast lecture. My name is Edit Gara, and today we are back to the cardiology topics. Today we will discuss acute coronary syndromes, ST segment elevation infarct, non-ST segment elevation infarct, and unstable angina. I hope that the CoROMcast so far were useful for you. Feel free to give us any feedback to improve these lectures. So today, this around 20 minutes discussion will be on acute coronary syndromes. Acute coronary syndrome, all of us as pre-hospital medical persons will meet many patients with acute coronary syndromes. This takes up a big slice from the whole pie in the pre-hospital emergencies, and unfortunately, it's a deadly one. There are two major groups of acute coronary syndromes. One is where we have ST segment elevation, and the other one is where we don't have ST segment elevation. So if you want to have an idea in your mind how to approach, this is the major approach towards acute coronary syndromes. You all must be very aware of the background, what's going on, what is happening. The pathophysiology. So the pathophysiology is that there is a coronary artery plaque. It's usually a lipid plaque, and this plaque has the tendency to rupture. So you all know that hyperlipidemia, obesity, lack of physical activity, diabetes, metabolic syndrome, etc. These are all risks for a coronary plaque rupture. When the plaque ruptures, there is a whole cascade of the pathophysiology starting. The site of the plaque is really thrombogenic, and platelets are drawn towards that place. In the unlucky scenario, those platelets can form a whole thrombus in the coronary artery. And in this case, there will be a full occlusion of the artery, resulting in an ST segment elevation, myocardial infarction, a STEMI. When you have a STEMI ECG, when you have a STEMI patient, you know that there is a full stenosis, complete blockage of a coronary artery. You have a picture in yourself what's going on in the arteries when you see an ST segment elevation ECG. And we all know that this is a terrible case for the patient, terrible pain in the chest, and they have a sensation of feeling like they immediately die, and unfortunately it can happen. So I would say that in my practice, in terms of the treatment, when you have a patient with STEMI, I would say, and I can say that I consider that as an easy peasy. I say this because when you have an ST segment elevation ECG, you are completely sure about the pathophysiology, you know what's going on. We have very strong, well-known protocols, how to treat the patients, what kind of medications to give, how to ease their pain, and how to rush them to hospital to do the coronary intervention. The tricky side is when you don't have the ST segment elevation. And when you don't have the ST segment elevation, we can, again, group further the cases. And one is the so-called non-STEMI, so non-ST segment elevation infarct, and the other group is the unstable angina. And these two, the recent guidelines, they are counted as one pathophysiology. So in these cases, mostly, we don't have the complete blockage, and that's why we don't have the ST segment elevation on the ECG. What do we see on an ECG when we have a non-STEMI or an unstable angina? I guess many of you are just thinking about what kind of ECG changes, what kind of ischemic signs can we have, I would answer to this question, that what do you see in a non-ST segment elevation infarct on the ECG, that you can see whatever exists. You can see anything. You can even have a completely normal or normalish ECG. In most of the cases, it's not normal, but it can be that there's only just a T wave negativity in some leads. It can be that you have a slight ST depression. It can be that you have a bundle branch block, which is some suspicious. It can be that you have an AV block. So the ECG is not that helpful in the diagnosis. In a non-ST segment elevation infarct, the patient will have the same infarct symptoms as we have in a STEMI, or it can be as severe the symptoms as in a STEMI. And we don't have the ST segment elevation, the ECG, and it's usually not a complete blockage. But, and this is the difference, that between the non-STEMI and the unstable angina, that in a non-STEMI, we have troponin outflow. So the diagnosis between the non-STEMI and the unstable angina is a laboratory diagnosis. Everything else is the same. So the non-STEMI is counted as a proper myocardial infarction. I mean proper, that from the laboratory site, you see the troponin outflow. In an unstable angina, you usually don't have troponin positivity, but the patient develops more severe angina than they used to have before. So the patients in unstable angina, I have an image in front of me, in my mind, about these patients. They are smoking, they have some obliterative artery disease. They can have peripheral artery disease in the legs as well. And they have a history of coronary artery diseases. And they might have some mild or non-significant stenosis on the coronary arteries with some calcification, with ugly-looking lipid plaques. And these patients usually have stable angina. And stable means that they have angina after a certain amount of steps, or they have angina usually in the morning, or they have developed pattern of their angina. And when this pattern is changing, that's when we call it an unstable angina. So it's this unstable, it's nothing to do about the hemodynamics of the patient. The unstable angina means that the patient develops the angina earlier than before. Earlier means like before they have been able to walk 10-15 minutes without angina, and today they have severe angina after 3 minutes. Or previously they could climb 2 stairs and now it's just 1. Okay, so this is the instability in it. So this is how the pathophysiology is counted. This is how you group the acute coronary syndromes. And so far we have discussed the STEMI, non-STEMI, and the unstable angina. Let's talk a bit about the ECGs. So as I mentioned before, STEMI is easy to recognize. You have to see a couple of ECGs. Sure, you have to have good practice in your hands to really quickly, just with one, it's just a blink, you recognize that this is a STEMI. The STEMI ECG gives us really a lot of information. You have to remember, or you have to study, or you have to have a sheet written on it to remember that which leads are standing for which coronary arteries. And this is helpful to study during your pre-hospital scenario, so when you are at the patient, because it gives you some more tips and hints how to handle the patient. So quickly, let's go through it. So the anterior leads, they usually stand for the left anterior descending artery, the LAD, The lateral ones are more connected to the circumflex artery. So the anterolateral region, lead 1 and AVL, usually for the circumflex, the CX, and the LAD is the V1, V4 leads. Okay. The inferior leads, lead 2, 3, and AVF, are the right coronary artery, or if it's a left dominant coronary circulation, it can be the CX. You will only know this once you have the coronary angiogram. All right, and you can also count with the right ventricle, which is connected to the inferior leads, and you can see some right ventricular hints in the V1 and V2. I would like to outline one critical severe condition, and that is the left main stenosis or the left main infarct. If you can group the STEMIs, then the left main STEMI is kind of the most threatening. In a left main infarct, in left main occlusion, you will have an ST segment elevation in AVR and only in AVR and none of the other leads. Usually AVR is like, we don't really want to deal with that. We don't know what is that showing, and AVR is just usually left out from all the ECG analysis. You should have a close look, and if there's a clear ST segment elevation in AVR and the patient has the typical STEMI symptoms, then it's a left main stenosis and it's critical. So the revascularization has to happen as soon as possible. I wanted to outline that the leads are giving you hints, and also I would like to touch on the RV. So if you have an RV infarct, then that's important not to overload the patient and also to count for RV-developed arrhythmias. Okay, next, as I just mentioned, the arrhythmias, I would like to also outline that nowadays acute coronary syndromes are very, very well treated in hospital scenarios with the percutaneous coronary interventions, so the PCIs. But this podcast is focusing on oyster and remote conditions. And in oyster and remote conditions, we don't have the capacity to run the patients to a hemodynamic laboratory, to a cardiology unit, and to give them the stents into the coronary arteries and save their lives. So I just mentioned before that kind of STEMI situation it's easy to treat, and you have the protocol and rush into the PCI lab. But as I imagine myself in a remote condition with a STEMI patient, then that's incredibly challenging situation. And I would like to go back to the arrhythmias, because it's the arrhythmia that kills the patient in a myocardial infarct. So infarct patients die from malignant arrhythmias. So they either develop a ventricular fibrillation or a ventricular tachycardia, they lose consciousness, they get into a CPR situation, and if the patient is lucky, then the medications and the shocks can stop that arrhythmia. Unfortunately, if not, then they die. So the killer is the arrhythmia. And before the PCIs existed and before they were so well developed, many patients suffered ST segment infarction without revascularization. I mean, they suffered the infarction, they had the really severe pain, they were hospitalized. Maybe a couple of days later, a cardiac ultrasound happened, but no angiogram, no coronary stenting. And I'm talking about the 80s, 70s. Yeah, and in the 90s, the PCIs were starting to really develop. So it's possible to survive a STEMI if the patient doesn't develop a malignant arrhythmia. Later on, of course, they will have a very severely decreased left ventricular function. They can develop a severe ballooning, a severe dilation of the left ventricle, because a part of the muscle becomes necrotic. It's the arrhythmia that kills. And when you are in remote conditions, oyster conditions, and you have an ALS background, so I assume that you will have a defibrillator on your hands. Use it. Try to save the life of the patient. If you don't have it, I would say that then no chance in a malignant arrhythmia. And even there is challenge when the patient doesn't develop an arrhythmia, because the evacuation takes up to 70-80 hours, and the patient should be revascularized in 12 hours. So what can you do in that condition? It's possible to give the thrombolytic drug. Nowadays we use the alteplase. It's really expensive drug, so it's not on all ALS teams. I'm not sure from which side of the world you are listening and whether your ALS teams have the thrombolytic medication in the bag. If so, and you know that the evacuation would take up more than 12 hours, then use the thrombolytic drug as soon as possible, because that can just damage the clot in the coronary artery, and it can reopen the artery and save myocardial muscle and increase the chances of malignant arrhythmia. So that's what can you do in the remote conditions. Again, unfortunately, these medications are really expensive, and not all of the emergency teams have them in the drug bag. Okay, in this podcast, we have discussed acute coronary syndromes, STEMI, non-STEMI, unstable angina. We have touched on the pathophysiology, grouped these acute coronary syndromes, discussed the differences between non-STEMI and unstable angina. I've also went through the infarct locations and the coronary arteries on the ECG leads, and also we've discussed the treatment and the major challenges. Just before I end, I would like to add that, and you all know that if you see a new onset left bundle branch block on an ECG and the patient has symptoms, that's count as an acute coronary syndrome and as a STEMI. I'm sure that you have studied this. So new onset left bundle branch block is equivalent with a STEMI. And with this take-home message, I would like to end today's podcast. Listen to our casts frequently. I will continue with the cardiology topics. Take very good care of your patients, and also take very good care of yourself, because we as physicians, medical persons, paramedics, emergency specialized healthcare professionals, unfortunately, we are prone to burnout, and you can't pour from an empty cup. So take very good care of yourself as well, and talk to you soon.
This has been a presentation from the College of Remote and Offshore Medicine Foundation. If you would like to earn CPD credit for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credits, free access to the virtual field guide, and discounts on our e-learning courses. You can join the team on the college website, which is COROM, COROM, corom.org.